Είναι στο web site διαδικτυακά ο κύριος Φιλιππάτος, ο οποίος είναι ένας εξαιρετικός φίλος. Έχουμε μια άλλη συνεργασία τουλάχιστον 25 χρόνια μαζί στο Αττικό Νοσοκομείο, ο οποίος θα κάνει το αρχικό introduction και μετά, επειδή έχει πρόβλημα με τη σύνδεση, θα συνεχίσουμε εγώ και η κυρία Παρχαρίδου να προλογίσουμε τους επόμενους ομιλητές. Οπότε, Γεράσιμε, έχεις το λόγο.
Καλημέρα σε όλους. Προσπαθούμε εδώ και μισή ώρα, λόγω ενός προβλήματος στον υπολογιστή μου, να λύσουμε τη σύνδεση, η οποία δεν είναι σταθερή. Εγώ απλώς θα ήθελα να πω δύο λόγια για αυτό το συνέδριο σταθμός, που πραγματικά προσφέρει εδώ και πάρα πολλά χρόνια μοναδική γνώση σε ένα δύσκολο θέμα, σε ένα θέμα που συνέχεια μαθαίνουμε, που έχει εξελίξεις. Και θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή και τον Πρόεδρο, τον καθηγητή Ευθυμιάδη, ο οποίος είναι πρωτοπόρος σε αυτό το χώρο, όχι μόνο στην Ελλάδα, αλλά και παγκόσμια. Και νομίζω ότι φαίνεται από το πρόγραμμα πως και οι ειδικοί και οι νεότεροι θα πάρουμε πολλές γνώσεις από αυτό το συνέδριο. Ευχαριστούμε πάρα πολύ, κύριε Ευθυμιάδη, αγαπητέ Γιώργο, για όσα μας έχεις προσφέρει όλα αυτά τα χρόνια, και παραδίδω στους προέδρους και θα τα πούμε και αργότερα στις επόμενες session, πάλι με περισσότερη συζήτηση, ελπίζω. Κύριε Παρχαρίδου, κύριε Παρίση, κύριε καθηγητά.
Ευχαριστούμε, Γεράσιμε. I will start with Professor Andre Keren. It's a great pleasure and honor to introduce Professor Andre Keren. He's a real legend in the field of cardiomyopathies. He's a very good friend for more than 15 years. And I hope to be, it's great also honor to be here. We'll speak about a clinical overview of myocarditis, presenting new data and the update of guidelines about myocarditis. Andre?
Thank you very much, and thank you for your kind invitation and the opportunity to learn, to participate at this excellent meeting, and the opportunity to meet so many good friends from much more than 15 years, John, much more. So I was asked to cover the topic of clinical overview of myocarditis, and I will base my actually short talk on two major documents. The one in which the Ministry of Health of Israel asked us to write a position statement on the diagnosis and management of myocarditis, a very clinical paper recently published, and the second one in which, together with Alida Caforio, we submitted to the Acute Cardiovascular Care Association a clinical decision toolkit update of 2024, hopefully to be done. So the background of, in speaking about clinical aspects of myocarditis, is that this disease induces persistent cardiac dysfunction in about 25% of cases, and about 25% of them develop advanced heart failure. And the second point is the sudden death in up to 12% of the adults and athletes who die is due to myocarditis by different papers. The prevalence of the disease ranges between 10 and 20 per 1,000. And in this extensive review of the literature we did, I show you this graph from with this paper. I show you this graph by which you can see that we have two peaks, one in early childhood and the other one in early adulthood. But it's very important to see that actually you can have the disease at any age. The old age does not exclude myocarditis, and the disease is more prevalent throughout life in male as compared with female. Now, I would like to cover these topics. You can see here quite a few, but only highlight them. The major issues on pathogenesis, new definitions, diagnostic red flags and pitfalls, indications for biopsy and genetic testing, and therapy, particularly what is the status of, in practice, not perhaps in guidelines, but in practice of current steroid treatment and immunosuppression. So about the pathogenesis, just to say that we still are with the same concept, which actually Kavai, about more than 2 decades ago, developed in the mice, by which the first phase of a few days is the viral invasion and the viral replication, intramyocytic replication, which is followed by viral clearance, which is achieved within the first 2 to 3 weeks since the start of the disease. And this point is very important, because if you will perform at the end of this period an additional biopsy, many times you will not find virus, and you can decide whether to give or not to give here steroid or immunosuppressive therapy. It's very important, this point of viral clearance, which is clearly induced by the immune response of the body, and then you are most of the people certainly recover without any problems, but then there is another subgroup, as I just said, where a chronic disease continues with developing dilated or non-dilated cardiomyopathy. Now, the major insults are by infectious triggers, viral triggers being the first ones, but then we can have toxins and hypersensitivity on a background of the environment. And today the microbiome is a major area which is researched in myocarditis. And then you can have also autoimmune conditions and genetic background, which will be very shortly discussed by me and much more by Aris in the next lecture. Now, these mechanisms you can see here, the components of the inflammatory process, can become both actually diagnostic tools, like, for example, in the line below, there is here, we can have, no, okay. So actually, in just the lower line, you can see the microRNA, and you can also, it can become also therapeutic targets. This is the first published paper in the New England Journal of Medicine in a few years ago on this microRNA, which not only made the diagnosis by a blood test, but also distinguished myocarditis from acute myocardial infarction, which would be, if we could have such a tool, then we really wouldn't need perhaps so many coronary angiographies in order to exclude myocardial infarction. The classic definition now about this concerning the myocarditis as a proven diagnosis required by classical definition, the endomyocardial biopsy, as you can see on the left side there, but more modern definitions do not require that anymore, and this is due to 2 developments: the high sensitivity troponin, and particularly the high accuracy of CMR in acute myocarditis. In our position statement, we proposed for simplicity to have the clinically suspected myocarditis, as it was already described 13 years ago in the position statement of the cardiomyopathy working group by Dr. Alida Caforio and colleagues, in which you had the clinical presentation, ECG, troponin, and echo Doppler. In addition, now if the test was positive and showed the typical findings on the CMR, then we call this category clinically confirmed, or if you feel more comfortable, you can say CMR confirmed. And then by endomyocardial biopsy, we have what is called pathologically proven myocarditis. I want only to make an important observation here, that using one element like it's recommended in the updated Lake-Lewis criteria, at least one element from the T2 mapping and one from the T1 mapping, this really gives a very accurate diagnosis, but only under one condition, and this is the acute phase. After 2-3 weeks, the accuracy of this test decreases significantly. By the way, this accuracy we can see here is also typical of the typical presentation like acute coronary syndrome. It's much less again, even during the acute phase, in heart failure or arrhythmic presentation. But let's focus on the acute versus chronic phase. In the chronic phase is much less accurate, and a few days ago, really during the last months or something, we had this first publication, which is the light at the end of the tunnel coming from Germany, in which using multiparametric CMR, actually in patients with chronic lymphocytic myocarditis proven, biopsy proven, or healed myocarditis, they made with high accuracy the diagnosis using specific parameters, which included, as you can see here, the T2 mapping, and then using on the lower panel, which is marked the radial systolic strain rate by MRR, and you can see the chronic myocarditis in red, showing significant different results from healed myocarditis, and these results were even more improved when CRP and troponin values were added to the evaluation of the patients. It's an important paper to read, particularly if you are in the business of CMR. And here is the area under the curve, which is very, very positive for both parameters of the tissue and the function parameters I just showed, with values of 0.87 and 86. And you all are aware, I'm sure about that the CMR also has prognostic implications, particularly when you have this mid-septal appearance or extensive CMR or ring-like CMR, which certainly I will also mention in a minute. Now, what about red flags and diagnostic pitfalls in a disease which can mimic many other conditions because of the different presentation modes, and pitfalls in diagnosis can be critical, and I will just show, because of the time limit, just actually some very short examples. So this is the first case, and my goal here is to speak with you about the Q wave, appearance of Q wave on the electrocardiogram of patients with acute myocarditis. Q wave does not mean acute myocardial infarction. It can occur in patients with acute myocarditis. This is a young patient who arrived, it's a publication, who arrived to the emergency room with this horrible electrocardiogram, and chest pain, which was misinterpreted as acute anterior and inferior wall MI, with not ST elevations, but also Q waves in all the leads. He got, at that time, thrombolysis and developed irreversible, intractable VT-VF, died, and on autopsy, extensive lymphocytic myocarditis was diagnosed, and the staff of the emergency room was sued for malpractice. So the issue of Q waves can be, like in this case, we published because of other reasons, not because of the Q waves, but anyway, it can be transient or, like in this case, persistent, and this case is having Q waves during acute myocarditis, either persistent or transient. They usually have a much more severe course, and the outcome, the prognosis is worse than patients with myocarditis without Q waves. So this is the Q waves. Another point I would like to make, where we changed our opinion and approach, is the fact that using this slide, which was part of Bromwald and any textbook you could go to, was that the concept was that in patients with fulminant myocarditis have a better long-term prognosis than those with non-fulminant presentation, as you can see here. Actually, on the left side up there, if you see, patients with fulminant myocarditis by this paper survived the first 2-3 days of the disease, giving time to the myocard to recover, then they lived actually forever. So this is a little bit incorrect, very much incorrect, and these are the first 2 papers in the literature showing this issue, but this was already, additional papers were published showing all the same. Actually, within the first 2 to 3 months, about 1/3 of the patients with fulminant myocarditis, fully treated by available mechanical support, either die or undergo heart transplantation. So this is not at all the picture we originally thought about, and this is an international study led by Enrico Amirati, and the other one is a national Japanese registry. And now a few words about the genetic background. Aris will speak much more about that, but just a few words. I corroborated with him my slides, so it won't be overlapped. And I believe that the next 3 slides show the whole story from a clinical point of view. This is an outstanding paper coming from French authors with the proband, as you can see him, having myocarditis. But he also had late gadolinium enhancement, significant ventricular arrhythmias, and late gadolinium enhancement of the ring type, which is here on the left upper side of the panel. And a very important issue, it has a very abnormal electrocardiogram, which shows very, very low voltage, actually almost no voltage. And then on family history, it turned out that he has a family history of dilated cardiomyopathy, sudden cardiac death, ventricular arrhythmias, these arrows, and additional patients with this ring-like appearance on their CMR. By the way, he had a normal echo, which is very typical, that they have only this discrepancy between the echo and the MRI findings, as you are probably well aware. And of the 6 families screened, 5 had this desmoplakin, 1 desmoglein mutation, and not did fulfill criteria for ARVC because this was arrhythmogenic left ventricular cardiomyopathy. And now the other end of the spectrum is this paper coming from Trieste, showing actually that in 36 patients with biopsy-proven lymphocytic myocarditis and persistent left ventricular dysfunction and other conditions, 1/3 actually in the upper panel you can see were evaluated, all were evaluated genetically. 1/3 showed pathogenic or likely pathogenic mutations, and actually of those with the most prevalent mutation, not surprisingly, was titin in those presenting with myocarditis and persistent left ventricular systolic dysfunction. And this background of presenting with what we call, Mary just told us it's not really myocarditis, but what we think clinically, it is myocarditis. And it can appear also in other conditions, the same issue. We have the predilection of developing thereafter left ventricular dysfunction, which persists due to alcohol and other postpartum and so on, might be a predisposition which is actually genetically determined. And this is probably the most important message concerning the genetic background of presentation of cardiomyopathies as myocarditis, which just was published, showing that in patients with complicated myocarditis, the prevalence of genetic background is tremendous. In adults, it's 22%, and in children with complicated course, 44% will have, by the literature review, will have a genetic mutation, pathogenic or likely pathogenic. In uncomplicated myocarditis, the number is much lower, only 4%. And again, the desmosomal and sarcomeric mutations are the most frequent, and among the sarcomeric, titin is the most frequent. And now just a few words about risk-based management. This is actually the flowchart we proposed, in which after making the diagnosis of clinically suspected myocarditis, as I just explained it, then we have to do absolutely obligatorily 3 things: to exclude coronary disease. We have to perform in all CMR, and the CMR should be performed either in hospital or within 2 to 3 weeks of presentation, and then decide if we need or don't need endomyocardial biopsy. When do we need endomyocardial biopsy? Only in patients who are complicated. Patients who are hemodynamically unstable, with complex ventricular arrhythmias, high degree AV blocks, persistently decreased RV and dysfunction, unresponsive to therapy, or in cardiogenic shock. Then these patients should be, as early as possible, transferred to tertiary centers where endomyocardial biopsy and mechanical support can be provided. And by the results, if there is lymphocytic myocarditis, usually we need just general support. But then, if there is no response, immunosuppression may be considered if they are viral negative. The other group is where we start immunosuppression by finding giant cell, eosinophilic, sarcoid, or ICI-related, immune complex inhibitor-related myocarditis. And only the last issue, steroids. Where do we stay today in clinical practice with steroids? So, first of all, steroids should be administered to those where I just previously mentioned, but then we should consider it also in fulminant myocarditis, cardiogenic shock, actually all high-risk patients, even before performing biopsy, particularly when we suppose that there might be also an immune background to this disease. And this approach, which is really applied today in clinical practice without much support in the literature yet, but this is what we do. We say, what do we have to lose in this patient with cardiogenic shock, is evaluated in the MITS trial these days. And then in the virus-negative inflammatory cardiomyopathy, we use the TIMIC protocol, and this is also now evaluated. This was a single-center randomized trial, but now this is a multi-center Polish trial going on, the IMPROVE MC trial, and you are well aware, I'm sure, that anakinra was evaluated and presented at the ESC. It had a neutral effect, it was safe, but did not decrease complication rates. And there are two trials going on, which appear on the slide, evaluating cannabidiol and colchicine in acute myocarditis. I will just say that we recommended first-line, second, and third-line therapies for all major, in our position statement, for all major conditions of acute myocarditis, and to return to physical activity, which will be also discussed here. And I would like only to give you the take-home message. That message is that most cases can be clinically confirmed by the clinical presentation, laboratory findings, primarily high sensitivity troponin and cardiac MRI. But in an important minority of patients, endomyocardial biopsy is required to prove the diagnosis, define the etiology, and for guiding the therapy. And patients with severe disease should be transferred as early as possible to a tertiary center where the approach, the diagnostic and therapeutic approaches, proper approaches could be applied. And in selected patients with severe presentation and or suspicion of immune etiology, IV steroids may be considered even prior to endomyocardial biopsy. And after we got the biopsy result, then we decide whether we continue and how we continue this therapy. And the last point, which we repeatedly emphasized in our position statement, is that in every single case, you have to take a family history and a personal history of previous myocarditis. And in patients with family history of myocarditis, cardiomyopathy, or sudden cardiac death, in those with CMR suggestive of arrhythmogenic cardiomyopathy, like this ring-like appearance, and in those with persistent LV dysfunction, genetic testing should be considered, and we do that now in every single case in our institution, particularly after we saw this paper I presented to you, and which shows the high proportion of patients with complicated cases who have genetic background. Thank you very much for your attention.
Thank you very much, Andre, for this excellent overview from a real legend in the field. There is time only for two short questions. Actually, a comment about the fulminant myocarditis cardiogenic shock. I think the basic treatment in this case is short-term mechanical support. There are very good data with ECMO versus acute coronary syndromes. Second, one comment about, we have some patients with very frequent ventricular ectopic systoles. And looking at the history, also performing a comprehensive evaluation by CMR, we found sometimes old myocarditis or subclinical myocarditis. What is your opinion about the management of these patients?
So these are exactly the patients who we used to overlook, and in using the CMR, actually in many of them, you find that you have extensive findings which are not present on the echo. And this is one of the reasons that every single position statement, and I'm sure upcoming guidelines now in the field, you know that the Americans have an in-press guideline, the Europeans have in-preparation guidelines, so we will have lots of guidelines. I'm sure we will have that. The obligatory CMR, even in mild cases, it's exactly to see this type of cases. And I can tell you that of the arrhythmogenic cardiomyopathies, a great proportion we had were mild formats. And we were absolutely surprised to see this extensive, sometimes CMR findings obligatory to see. And you always have to combine these two things. You might be surprised and you find arrhythmogenic cardiomyopathy, which will be presented by my good friend Aris.
Thank you. One question here.
Thank you, Professor Keren, for the fascinating talk. I'm actually very happy that you pointed out that sometimes we just don't have the time to diagnose virus-negative myocarditis and fulminant myocarditis, and by experience we give steroids. However, in cases where we have the time to perform a biopsy and do a PCR, viral PCR on the biopsy specimen, do we have standardized cutoffs for what we define as virus negative or virus positive? Because there is colonization by parvovirus, for example.
The classical approach.
I know you've heard this question a lot.
I know this is a fantastic question. I agree. Your question was also very good, by the way, John. I want to remain friends with you. So the basic issue is really a very important question, because classically what we said, that you have to have more than 500 copies per microgram of biopsy and so on. Many people consider that as being roughly not a correct way to say that this is an active or inactive, particularly in parvovirus and so on. So this issue is really not solved yet. We should have had microRNAs and messenger RNAs evaluated to see that this is really an active replication and so on. I don't know, this is really an extraordinarily important point. I don't know if you would like to add, Mary, to this point.
We are at the moment doing guidelines from pathology with our American and European associations, and we're not using virus deliberately. We're doing it on the biopsy alone, on the amount of inflammatory cells. The same with autopsy. Autopsy only does histology.
How you say that the parvovirus is a bystander?
Yeah.
This was the question, I believe.
Parvovirus is generally, I'm very skeptical about parvovirus results. We don't depend on the virus results. We depend on the amount of inflammatory cells in the biopsy, combined with immunocytochemistry for both macrophages and lymphocytes. That's what we are deciding in the guide. We're not going on the viral load that we see. And then also, in a lot of biopsies, it's virus negative anyway. So in a lot where there's a lot of inflammation, whether it's autoimmune, etc., is another controversial.
We have given steroids in very difficult situations. Also, when we found parvovirus, we tried to see the viral load, because this was that time the recommendation when we had this patient, and it was very successful. And Carsten Cecchi actually published a paper and a small study where they found the same, that and they also used the viral load in this small paper. So I don't know where we really will stay by the guidelines, but when you have nothing to lose, probably you still do that in patients with parvovirus.
Correct, and pediatric versus adults, much more viruses in pediatrics compared to the adult as well. I think the whole area is extremely controversial. We rarely get viruses in our positivity, in the adult population.
Particularly
so
when you wait for 2-3 weeks.
Yeah.
Then it's more frequent that there is no virus, and then you certainly
most are not going to be acutely diagnosed. It's several. you are right, the symptoms are vague and can be weak later as in the majority of cases. But interesting about acute fulminant myocarditis and the rapid recovery that can occur as well. Quite dramatic, isn't it?
Yeah, sometimes not.
And of course, the controversy in COVID is the macrophage rich. As you know, lymphocytic is in COVID almost unknown, very few, but lots with macrophages, and the role of the macrophage and its entity in myocarditis is something that we pathologists don't see. You have to use immunostain to see the macrophage because they're kind of not really very obvious on a normal biopsy. But the problem with it is that we've all have a population of inflammatory cells in all of us within our myocardium, a few T cells and a few macro. Every myocyte has a T cell and a macrophage. We think looking after it on the thing.
We do not believe there is real myocarditis in COVID-19 itself.
No, not as we know it, yes.
Thank you very much. Για οικονομία χρόνου να προχωρήσουμε.
Sorry, there is no time for other questions after the meeting, because there's συνέχιση.